Welcome to this special RPTH research recap, where we dive a little deeper into the science being published at Research and Practice in Thrombosis and Hemostasis. Today's recap is in honor of World Hemophilia Day, a global opportunity to raise awareness, advocate for equitable care, and recognize the ongoing challenges faced by people living with hemophilia. My name is Brian Branchford. I'm a pediatric hematologist at Children's Wisconsin and the Medical College of Wisconsin, which is located in Milwaukee, Wisconsin in the USA. I take care of kids with blood clots and bleeding disorders primarily at Versity's Comprehensive Center for Blood Disorders. I do clinical research on risk factors for and prevention of pediatric hospital-acquired thrombosis through the Children's Healthcare Advances in Thrombosis chat. I do that through Versity's Medical Sciences Institute, and I also have a basic science lab at Versity's Blood Research Institute studying platelet activation and thrombosis in the setting of inflammation using some murine models. It's my very great pleasure today to introduce Cedric Hermans, our speaker. Dr. Hermans, who you see here, is the head of the Division of Adult Hematology, the Hemostasis and Thrombosis Unit in the Hemophilia Center at the University of Saint-Luc in Brussels. He's also a full professor at the Medical School of Catholic University of Louvain. Also mentioned he's a former president of EHAD, member of the board of directors for the World Federation of Hemophilia, and editor-in-chief of the Hemophilia Journal. So we're going to learn a lot from Dr. Hermans today. His main research interests are clinical studies of treatment modalities in the wide range of complications in hemophilia in both developed and resource-limited countries, as well as new anticoagulants, the management and prevention of thrombotic conditions. So we're here today to talk about Dr. Hermans' new paper in RPTH that's titled Extending Health Equity to People with Moderate and Mild Hemophilia A, Revisiting the Haven 6 Trial. We're excited to discuss this important work today on World Hemophilia Day as the global bleeding disorders community comes together to raise awareness and advocate for equitable care for all. So those of you joining us live, please leave any comments or questions in the comment section or the chat. And we will get to those questions after the presentation during our discussion session. So, Dr. Hermans, we look forward to hearing your presentation.
Well, thank you. And thank you, Brian, for this opportunity, especially on the World Hemophilia Day. I think this is a great paper to discuss today. So I'll share my slides. Okay, seems to be working. So this is the title of the work that I will shortly discuss today. So extending health equity to people with moderate and mild hemophilia, because this is really the focus of today, revisiting an important trial that was published in the Lancet Hematology in 2023 and also presented at ISTH in London 2 years ago. This is the Haven 6 trial. And I will present you this work and this paper on behalf of my colleagues who are listed on the slide here: Michiel Coppens, Juliana Ventriglia, Gavin Link, Michael Lele, and my friend and colleague, Stephen Pipe. So as you all know, and the Hemophilia Day is certainly a great opportunity to acknowledge this, we now live in a totally new hemophilia environment with totally new perspective. Well, why is it like this? Well, as you all know, a significant proportion of people with non-severe hemophilia display a severe bleeding phenotype. So these patients, although they have more than 1-2% of factor VIII, factor IX, well, they present with joint disease or even uncontrollable life-threatening bleed. So clearly, severe bleeding phenotype is present and does affect people with non-severe hemophilia. The second one is regarding the traditional approach to prophylaxis. As you all know, using short-acting factor VIII and factor IX in the past, the goal has long been to convert severe hemophilia into moderate hemophilia. So just trying to keep the factor VIII level slightly above 1-2%, because clearly the bleeding phenotype is significantly different. But now we can witness a major paradigm shift. Why? Because multiple new treatment options are available, and they have in common to enable sustained high factor levels, with the aim of, in some patients, potentially normalizing their hemostasis. So clearly, there is a need, there is an opportunity to think about prophylaxis in non-severe hemophilia patients, valuing the new therapies, and that will be the subject of my presentation today. So this visual slide shows you that, well, classically, hemophilia has been classified, categorized according to the factor level measured in the blood, clearly distinguishing the patient with a severe disease. These patients typically have non-measurable factor VIII in their blood below 1%, and these patients are expected to bleed a lot. Patients with moderate disease who have levels between 1, 2, 4, 5%, they bleed much less frequently. And patients with mild disease who have levels above 5 up to 40, 45. And the classifications of hemophilia has been based on this, with the clear ambition to convert severe into moderate in severe patient. But the reality is totally different, not only in male patient, but also in female patient, because we know that, and that was a little bit unexpected, but this is totally in line with our clinical observation. Well, some patients with non-severe hemophilia, some patients with moderate hemophilia, even a few of them with mild hemophilia, do bleed much more than expected. And in fact, these patients do present a bleeding phenotype that could qualify as a severe phenotype. So why is it like this? Well, it's clear that the bleeding phenotype is not exclusively determined by the factor VIII or the factor IX levels in the blood. Well, clearly, the factor activity levels is influenced by the genotype, by X chromosome inactivation in females, also by the factor VIII pharmacokinetics, and that has been very important over the last decade to tailor the treatment. And we know that this pharmacokinetic behavior is influenced by the age, the body mass index, the von Willebrand factor, the blood group, and all these different components can contribute to deficient hemostasis in person with moderate and mild hemophilia. So it's clear that the factor VIII activity levels are only one part of the story. A number of other genetic and non-genetic factors are considered to influence the bleeding phenotype, illustrating that, well, clearly the simplistic nature of treating according to the factor VIII levels in the blood is probably not appropriate. So plenty of factors need to take into account, and it's clear that the audience today is familiar with the complexity of blood coagulation and all the parameters and factors that could modify the phenotype. And this is also clearly illustrated in different studies. We have plenty of data showing that there might be a major discrepancy between the levels and the clinical presentation. And just to highlight this, illustrate this, I would like to share with you some of the results of a large study, the PROBE study. In that study, nearly 10% of the male patients with mild hemophilia, 31% of the males with moderate hemophilia, and 5% of the females with mild hemophilia had an annual bleeding rate, an ABR, above 10. And that happened in spite of a significant proportion of these patients receiving regular or intermittent prophylaxis. I will not go in the details of the proportion of these patients. And this is also reflected by observations made in this important trial that we'll discuss today, the AVEN6 trial. Well, clearly, the reasons reported in that trial by the investigators for participants to require prophylaxis were multiple, and they are listed here on the slide: history of frequent bleeding, history of frequent joint bleeding, history of severe bleeding, or prevention of traumatic bleed. So there might be many reasons why patients with non-severe hemophilia, moderate or mild, would be eligible for prophylaxis. And this is, I think, a nice illustrative visual slide showing you what's the current treatment paradigm. So clearly for decades, because of the limitation of the treatment that we had in the past, the ambition was to convert severe patients into moderate patients. Because realistically, this is what you can achieve with short-acting factor 8, factor 9, given frequently. Today, with a new treatment option, it's possible to convert the severe into mild patient, and even in some of them, normal hemostasis. But that also shows that there is an opportunity for patients with moderate disease to be converted into mild patient, and for mild patient to be normalized. Also, there might be an opportunity to convert moderate patient into normal hemostasis. And I think it makes sense. I increasingly realize in my practice that the moderate of today, in fact, these are the new severe patients, considering that many severe patients, or most of them, are now on the new treatment. We have to regret that few studies have so far evaluated the use of prophylaxis in people with moderate and mild hemophilia. So this is a quick summary of the data that we have, a review of the literature from 2022 examining prophylactic use of factor replacement in persons with non-severe hemophilia clearly showed a major gap in knowledge. And you can see here the number of articles that included a large number of patients, more than 2,000, with mild moderate hemophilia A. Only 22 or 29 of them, respectively the mild and the moderate, for these patients, the treatment regimen was reported. Treatment regimens were often undocumented, and the outcomes were not consistently reported. And this is totally in contrast with what we see in patients with severe disease. Nearly all mild hemophilia A patients for whom treatment regimens were reported received desmopressin, and details of treatment regimens for women with hemophilia were really sparse. And most studies also were conducted in high-income countries. So clearly, major limitation and efforts should be devoted to solving the situation. So coming back to this AVEN 6 trials, for those of you who might not be familiar with that trial, so the key inclusion criteria are summarized in the green box in the middle. So these are patients with moderate or mild hemophilia, well characterized. They don't have an inhibitor. And for this patient, need for prophylaxis was clearly documented and was assessed by the investigators. There was no age restrictions. So there were in total 73 people recruited, including 3 women. I'll come back to them. 52 had moderate hemophilia A, 21 had mild hemophilia A. These patients classically received a loading dose of emicizumab, 3 milligram per kg for 4 weeks, and then they were started on the maintenance dose according to the participant choice, and that was 1.5 every week, 3 every 2 weeks, or 6 milligram per kg every 4 weeks. And I would like quickly to revisit with you this AVEN 6 trial and try to examine the clinical implication and explore the future direction for treating persons with moderate and mild hemophilia. So first of all, in terms of efficacy of emicizumab in this population of more than 70 patients, you can see here that there was a significant impact on the bleeding phenotype. So the pre-study ABR model-based was more than 10, but it decreased significantly. And you don't need to be a skilled statistician to see that whole bleeds were significantly lower, 2.3, and the treated bleeds were also less than 1 over a follow-up period of approximately 55 weeks, if I'm correct. Important to stress the fact, as illustrated in the green box, that the target joint resolution was documented in more than 95% of the participants who had target joints at baseline. So again, a very good results. And 96% of the participants who completed the AMI-PREF questionnaire, so this is a questionnaire evaluating the preference on the patient side. Well, as you can see, 96% of these patients expressed preference for emicizumab compared to their previous treatment. Important to stress the fact that there were 3 women and girls with moderate or mild hemophilia A in that trial. Well, I need to emphasize that a more detailed description of the impact of emicizumab in these 3 women and girls have been previously reported separately in another paper previously published in RPTH. So I will not go into details, but as you can see, one of these women had moderate hemophilia, 2 had mild hemophilia. The 3 of them were clearly candidates for prophylaxis. Some of them had a lot of bleeds before the study. Well, clearly the study, during that study, it was clearly demonstrated that emicizumab had a major impact on their bleeding phenotype. I need to emphasize that the case in the middle, participant 2, who was in fact one of my patients, had multiple bleeding symptoms, maybe also related to degree of hyperlaxity and collagen weakness. But it's clear, and without going in the details, the results in this woman were totally aligned with what we have seen in male patients. Also, and important to stress the fact that it was possible to evaluate the impact of emicizumab on women and girl specific outcome, gynecological outcome, since there was a major impact on their menstruation. So something that would not be totally expected, considering that emicizumab is correcting factor VIII, but not primary hemostasis. But there was a positive impact. Now, if we look at the pharmacokinetics and pharmacodynamics, and I think these are also important data, because some people were a little bit concerned by the fact of combining emicizumab with factor VIII that these patients do produce because of their hemophilia status. Well, clearly, the pharmacodynamic analysis from this AVEN 6, including measures of factor VIII-like activity, as well as thrombin generation test, aligned with preclinical prediction and indicated that the emicizumab dose used did not exceed expected levels. And these data again support the safety of using standard emicizumab dosing regimen in these patients, as in patients with severe hemophilia. I would like also to share with you some safety data. So in this AVEN 6 trial, there was one thrombotic event that was observed after a median safety follow-up of 55 weeks. We need to consider what kind of thrombosis it was, and I need to emphasize that this was a grade 1 thrombosis hemorrhoid that was classified as a thrombotic event according to the medical dictionary for regulatory activity system, but this was exclusively an hemorrhoid that was thrombosis. Also, I need to emphasize the fact that in this AVEN 6 trial, as you can see on the right part of the slide, 31% of the participants with moderate hemophilia A and 38% of the participants with mild hemophilia received on-demand factor VIII for a breakthrough bleed. And in all these patients, there was no associated thrombotic events or thrombotic microangiopathy. So these are also reassuring data if needed. Also, in terms of equity and equality, I think what this trial shows and what this paper does discuss is that, well, clearly prophylactic care should, in our view, and this is what we discuss extensively in that paper, that prophylaxis should be considered for any person with moderate or mild hemophilia who has a disease burden, that prophylaxis may be expected to improve according to the patient's reported experience or the treating physician's judgment. And I think this is an important piece of information. So clearly prophylaxis should not be exclusively restricted to patients with severe disease. And clearly the opportunity to use the expanded range of therapeutic advances or advancement that we now have offer this option, makes this prophylactic possible for people with moderate or mild hemophilia. And maybe this is not yet enough exploited. I think maybe more efforts are needed. And in our paper, this is something we discuss extensively, the importance to stimulate, motivate proactively people to adopt a prophylaxis if needed. And clearly, the bleeding phenotype should be taken into account. And I think also that this is an important slide that probably encapsulate important messages of our paper. Well, clearly the laboratory diagnosis of hemophilia is and remains really important. It's important to know whether the patients have a factor VIII levels below 1%, between 1 and 5, or are in the mild range. I think this is critically important. But at the same time, the bleeding phenotype should be assessed, should be evaluated over time. And it's clear that based on the clinical bleeding phenotype, some people, even if they have moderate or mild hemophilia, should be considered as severe patient. And if they have a severe bleeding phenotype, we feel that this patient should be considered candidate for prophylaxis. It's also true that some patients with severe disease bleed less than expected, but I will not discuss this today. In our view, if you have severe hemophilia, you should remain on factor VIII, factor IX prophylaxis or alternative treatment. It's clear that it might not be that easy to define a severe bleeding phenotype. So how can we do this? Well, if you are aware of the recent literature, there are several papers that have tried to analyze this, discuss this extensively. Well, clearly the risk for bleeding, the presence of comorbidities, early signs of joint degeneration, the patient expectations, their lifestyle, their daily activity, the bleeding phenotype defined according to the age or the timing of the first bleed, the first joint bleed, was it before the age of 2? If the patient had spontaneous bleeds in critical site, or if the patient had spontaneous bleeds repeatedly over the year, or had a major potentially life-threatening bleeds. I think that all these patients would clearly qualify as severe, as having a severe bleeding phenotype. And in our view, this patient should be potentially candidate for prophylaxis if possible. So to conclude, I would like to share with you some statements or observation. Well, clearly, prophylaxis has evolved a lot over the last decade, and it's clear that the therapeutic advances have completely shifted the profile of patients with hemophilia who may benefit from prophylaxis. And this is not only true for patients with severe disease, this is also true for patients with moderate and some patients with mild hemophilia. And in our view, and I think this is strongly supported by the AVEN6 trial, there is no evidence supporting prophylaxis in non-severe hemophilia A patient. And I think the AVEN6 trial really paved the way to more trials, focusing on the specific population, but the evidence is growing for this non-severe patient. And not only male patients, but also female patients. And the AVEN6 trials provide important data regarding this population, including women and girls, even if the population was quite small in AVEN6, only 3 patients. But that should motivate and stimulate us to enroll more women and girls in that kind of trial. Clearly, there is a need to update the treatment guidelines for the future, although the latest guidelines already emphasize the need to pay more attention to the phenotype rather than focusing exclusively on the levels. And I think this is important today if we want to improve equity in our field. So we need to listen to the patient, take into account the patient experience, and make sure that there is no segregation within our patient. It's clear that moderate, mild hemophilia A patients are clearly candidates for prophylaxis. And these patients should be identified. We should have an open discussions with them. We should implement this process of shared decision-making and make sure that we agree with them that prophylaxis is the way to go. So this is, I think, my last slide, and I would like to acknowledge all the people who made that trial possible, and then the other publication that were produced, all the patients, the study investigators, all the critical people who coordinate the trial, all the study nurse, the sponsor, and my colleagues who helped me developing this short PowerPoint shared with you today. Thank you.
Thanks a lot, Cedric, for that excellent presentation. It's especially meaningful to highlight and share this important research on World Hemophilia Day and really help recognize this group of people and increase awareness about the cohort with non-severe hemophilia, because that is sort of a disproportionate portion of our focus, typically. And I liked what you said, that moderate is the new severe, and that really resonated with me in terms of how I might change my practice going forward. You mentioned paradigm shift a number of times in how we think about these things, and I think I'm having a shift in my thinking as well, that we've had a lot of focus on severe hemophilia for a long time, and now let's try to catch up and provide equity in our treatment for people with non-severe hemophilia. Another way in which my thinking is shifting as this paradigm changes is thinking of hemophilia less by the levels in laboratory evaluation and more by the clinical phenotype, as you so elegantly pointed out. It's becoming a little bit more like von Willebrand disease in my mind, which is another disease that a lot of us treat that is kind of well known for having a variable clinical phenotype where the genotype and phenotype correlation, or the factor level and bleeding phenotype, don't match, and a lot of times it seems like that is very vexing for providers and patients. And when I'm talking to patients with von Willebrand disease, I've always compared it to hemophilia in the past. Hemophilia's got these well-defined levels, and you sort of bleed according to how low your levels are. But I'm definitely planning on changing that approach, that comparison, because I think you've demonstrated very nicely how that's not necessarily the case, and there may be a lot of variability in the clinical phenotype that doesn't always match up with the factor levels for hemophilia. And you mentioned a few of the other non-genetic aspects too. But this sort of goes along, I think, with some other changes in the field of hemophilia, where we are moving towards more of the buzzword worthy approaches like precision medicine or personalized medicine, where we're looking at each individual patient and their bleeding phenotype and doing personalized pharmacokinetic studies to see how this patient responds to that factor product and what's going to be the best for them based on their activity level and their social schedule and things like that. And not just doing a one-size-fits-all approach. You have a level of 3%, so we're going to treat you the same way we treat all people with 3%, because, as you've shown, 3% does not mean the same thing across the board. And it's becoming a little bit more like oncology, where we say, okay, not everybody with the same kind of tumor has the same outcome and therefore doesn't get the same treatment. There are some genetic modifiers, or there are treatment response modifiers, and these sorts of things. So we're being able to, I think, offer more specific patient relevant therapy, which is really helpful too. And it, like I said, folds in with the way that the field seems to be moving away from objective measurements that researchers like annualized bleeding rate, and going towards patient reported outcomes like quality of life and things like that. And so your work fits right in with this shift of hemophilia towards more personalized approach, and I think it was well received by our audience.
Yeah, although I'd like to stress the fact that, I think these are complementary approach. I think the laboratory diagnosis and the diagnosis severity based on the levels remains critical. I think this is very, very important, but we shouldn't only rely on this. We also have to pay attention to the phenotype. And if your patient has 5%, you need to be ready to see some joint damage, ankle arthropathy. And this is something that can happen. And if this is the case, well, you shouldn't be passive. We now have treatment options, and these patients should be on prophy. And especially for the next generation, we don't want in the future to have severe patients who have been perfectly treated and then realize in 10, 15 years that we have not been proactive enough with some moderate patients who had 3, 4, 5%, and then regret that we didn't do anything for them. So that's why I think we need to be proactive. We need to study this population. But let's be honest, we don't have that many patients with moderate hemophilia. Okay, so look at your
Mhm.
population of patient. It's different from hemophilia B. How patient with hemophilia B do distribute between severe, moderate, and mild is different. Moderate A, we don't have that many, and also among the mild patient, if you go back to your center, you look at your data, you don't have that many patients with hemophilia A with levels between 5 and 10. You don't have that many of them. So this is not a huge group of people. So I think we have time today to invest a little bit of our resources and energy of that population, and certainly also in women and girls.
Yeah, these are excellent points. And we've had a few comments come in. People have been pleased with the presentation and appreciated its timeliness, and really enjoy that. If you're joining us live, please feel free to put any other questions in the chat function. I'll start with one real brief one we have talked about before. The concerns that some people have about going completely away from factor VIII replacement therapy, at least in severe hemophilia, to a bispecific antibody like emicizumab or other non-factor therapies that are in development, because there may be non-hemostatic functions of factor VIII that the patient may benefit from if they're getting that. But my understanding is that that would be less of a concern for this group of patients, the moderate and mild hemophilia, because they make some native factor VIII, just not normal amounts. So it seems like there is less risk of, like you said, getting down 10, 15 years down the road and find out we've been depriving these patients of some other important factor of or consequence of factor VIII, like bone health or immune system development or some other factors we probably have yet to figure out. Is that true?
Yeah, well, this is a question mark. I know that some people have concerns about not providing at least a little bit of factor VIII in some of our patients. But let's be honest, replacing factor VIII is a real challenge. It has a short half-life. It needs to be given IV. It's highly immunogenic. So we are lucky. We now have, a new generations of factor VIII with a much longer half-life. So that could help. I know, but at the same time, we need to accept that for some patient, intravenous access is really challenging, if not impossible. So I think we need to look at the real net benefit. And I've been involved in many twinning programs in low resource countries, and I've seen patients who spent most of their life without factor VIII at all. Okay, so these patients, I don't see plenty of comorbidities, new comorbidities that we are not expecting. I've seen patients who have spent all their life with a potent inhibitor. So these patients had virtually no factor VIII. I haven't seen major impact. What I see is that with the new treatment option, these patients probably are much more active physically, and maybe that could compensate the health status, the joint status, the bone status. But we need to remain vigilant. We need to study this. And I think that in our community, we like generating new data. We like studying our patient, and it's clear that in patients on EMI, we've spent many, many years on EMI or other non-replacement. It will be important to look at this. It will be important, but I'm not personally that concerned about this.
Good. Yeah. Excellent points. Thank you. We've got a question in the chat from Angela Moffat. I noticed that some quality of life indicators are actually scored worse or lower for moderate patients versus severe. Is that due to the level of care or treatment intervention? And you see it here on the screen.
Well, maybe that could reflect the fact that, yes, these patients, well, we have invested so much time, energy, resources in severe patients that we have probably neglected the mild and the moderate, and maybe that could be the reflection of this. I don't have other good explanation for this. No, it's clear that if you survey your moderate and mild patient, you might be surprised by the burden of the disease. Although, 15 years ago, in this moderate patient, we try to reassure them, and we told them, be happy. You have the levels that all the severe patients are fighting for every day. Well, I think that was the vision and the practice at that time, but today, this is not longer what we can recommend and adopt. Yeah.
Thank you. One other question I had was thinking back 10 or 15 years ago when I started using emicizumab, or we started talking about the use of it for patients. One question we had was, at what level will it stop being useful? Like we know from some surgery studies that it's okay to give extra factor VIII, say recombinant factor VIII or plasma-derived factor VIII to someone who's taking emicizumab, and that human factor VIII compound will kind of bump the emicizumab off of the activated factor IX and the factor X and replace it for a while until it's catabolized. So you're not necessarily having additive amounts. So we are able to safely dose patients a little bit higher than they might get with emicizumab alone for major invasive procedures or in the setting of major injury, that sort of thing. But it's always been a question of exactly how much are they getting, and we can get some sort of indirect measurements. You showed thrombin generation. We can talk about bleeding phenotype is like that of patients with this factor level, but it's been hard to get our finger on it, kind of how much they had. But I really enjoyed your graph where you showed on the y-axis the factor VIII-like activity at the different dosing regimens, the 5 milligrams q week, 1.5 milligrams q week, 3 milligrams every 2 weeks, or 6 milligrams once a month, and showed sort of, maybe a low of 10 where they started, and about up to 40 with the loading doses, and then they sort of seemed like it was considering leveling out around the 20 to 30% range. And I think that is a helpful sort of thing to know, an approximate factor VIII-like level that we can expect from emicizumab therapy. Is understanding in that area helping what you're doing in your research and how you're taking care of patients?
Well, this is a difficult question, as many people are working hard on trying to define, what's the equivalent factor VIII activity. We anticipate that it should be somewhere between 10, 15, 20, but I think there might be a little bit more variability. But I think this is correct. When you follow many of these patients on AMI, I would say that they more or less behave as someone with 15, 20. It's important to stress the fact that in the AVEN 6, there were some people with mild hemophilia. And some of them, you would say, why should they be treated with AMI, looking at their levels? Well, these patients, got some benefits of this. So maybe, the way this work, the way this drug is acting, or the level that we measure in the blood, or, they probably not fully reflect, what's really going on in the body. So I think we need to learn a little bit more about this. I think the good news is that, as you know, the bispecific antibody that we now have, this is some sort of first generation, and companies are working hard to develop new versions with more affinity for factor IX, factor X. And when you look at the data, this new bispecific has the potential really to normalize coagulation. So it's clear that for non-severe patients, these agents will have probably even more dramatic impact in the future. And maybe you will invite me back in a couple of years. Let's see. But why? Maybe this super bispecific or second generation will play an important role in the treatment of this patient, and also in women and girls who have factor VIII deficiency. Because, well, many of these women have level, that are around 20, 25%. So maybe they not sure that all of them would be good candidates for AMI, but they might benefit from the next generation. So I think, this AVEN 6 really paved the way to a new era where we have to study these patients with moderate hemophilia. There is something that we did not discuss extensively. Is how do we conduct clinical trials in this specific population? So clearly, we'll have to work actively on this, define the ideal trial design to study the benefit of this new treatment in non-severe patients, including women and girls with specific outcomes measures. I think that will be important. And again, even 6 paved the way to this. That trial has been criticized. It has some weaknesses, but it was a huge effort, and it brings very important information. But clearly, efforts are now needed to define how we will conduct this kind of trial in the future. These data are important.
Wonderful. Yes, those are very helpful thoughts. I've not seen any other questions or comments come in other than people continuing to express their appreciation of an excellent presentation. I heartily agree. So maybe at this point, I'll wrap it up and thank you so much for presenting your work and giving us some insight into how we can extend health equity to people with moderate or mild congenital hemophilia A on this very special and timely World Hemophilia Day research recap through RPTH. We hope that the viewers will read the full detail of your paper on our website, rpthjournal.org. And thank you again to all the audience. Otherwise, it would be just Cedric and I talking, which I would enjoy, but may not be as helpful to others. We appreciate you joining us live, but please don't forget to follow us on LinkedIn, Facebook, Blue Sky, Twitter or X, and YouTube. We're in all the places. So thank you for watching. Keep an eye out for the next RPTH recap coming up in May. Any final thoughts from your end, Cedric?
Well, Brian, thank you. It was a great opportunity first on this Hemophilia Day, and a great topic, I have to admit. Mild, moderate, women, girls, new data, new drugs, new innovations. So clearly showing how enthusiastic and optimistic we can be. So thank you for giving me the opportunity to share this paper today. It was great. Thank you.
Yes, you're welcome. Okay, everybody have a great day and happy World Hemophilia Day.